Hello everyone, welcome to Patho Excellence. In a previous video of skin biopsy interpretation, we have discussed many important dermatopathology definitions. Now, when we do skin biopsy microscopy, it is often considered difficult, not because the slides are complex, but because the approach is unstructured. And most mistakes happen when we jump straight to the high power. So in this video, I will show you a simple step-by-step checklist approach that will help you read any inflammatory skin biopsy confidently. And here we will discuss microscopy in detail so that it will be easier for you to diagnose skin biopsy easily. Now in this video we are going to discuss what are the important informations required for biopsy diagnosis, how to approach inflammatory skin biopsy, a complete microscopy guide, and most important, checklist, because a checklist converts slide viewing into slide interpretation and diagnosis. And how will you interpret and how will you write down your final reporting line or diagnosis. So let's see what are the informations, what type of informations required in the biopsy request form. So first of all, general informations and then relevant history. So general information regarding patient's age, name of clinician, date and procedure, whether it is punch biopsy, incisional biopsy or shave biopsy, right? What is anatomic site of specimen, clinical information as well as clinical diagnosis. Relevant history include duration of lesion, previous excision if present, family history of some such type of or any other cutaneous lesion, history of any immunosuppression, radiation exposure or any chemical exposure, any autoimmune disease or pregnancy or any malignancy related history, along with any history of travel to foreign countries. Now another relevant findings is the particular description of lesion which we are going to diagnose. So whether it is bulla, macule or patch or papule plaque, etc., that we have already discussed in our previous video. So most important information includes lesion number and distribution, description of lesion, whether it is pigmented, its color, nature, shape or outline, ulceration and hemorrhage. Shape may be either annular or figurate or gyrate or irregular, whether it is bullous or not, whether it is painful or non-tender, as well as whether it is fixed to deeper tissue or not. So why this information is required? Because there is a clinical diagnosis based on these all features of lesion. And in skin biopsy, grossing of skin biopsy is equal to clinical diagnosis. So dermatologist provides us some differential diagnosis on the basis of their clinical examination, and this will act as a grossing of skin biopsy. So now how to approach this skin biopsy, particularly inflammatory lesions. So here what you need to do is you need to learn proper description of findings in the term of dermatology definitions. These all definitions we have already discussed in our previous video. So if you haven't seen yet this video, then go for dermatology definitions in detail, and you will learn how to identify these definitions and how to identify under microscopy, and you will make up some clinical dermatology definitions properly identifiable in the microscopy. Now A systemic analysis of biopsy is necessary. This is very important. When you start microscopy, start from the uppermost layer, which is keratin layer, then epidermis, dermo-epidermal junction, superficial and deep dermis, fat, and finally the blood vessels. Here it is very well known that the diagnosis of inflammatory disease is the toughest, whereas diagnosis of tumor is the easiest in case of skin biopsy, and diagnosis of granuloma is of intermediate difficulty. Now let's start with a step-by-step systematic approach. So first of all, always use a scanner view and never start with high power, because a scanner view will help you to assess orientation and adequacy of biopsy. So here in this scanner view, you can identify this biopsy is adequate because it contains epidermis, dermis having superficial and deep, as well as if a subcutaneous tissue is present or not. So identify all layers like epidermis, junction, dermis and subcutaneous tissue with the help of low power. And we can also identify overall pattern in some of the disease, because here diagnosis in dermatopathology is pattern based. So you should make one pattern with the help of scanner view in the under microscope. So here you can identify this is a adequate biopsy, where you can identify this is epidermis, this is dermo-epidermal junction, and here at the junction you can identify one cleft, right? And here this is deep dermis. So with the help of low power view, you can judge this is one type of a bullous lesion. Now next step will be your identify or the type of bulla you have to identify. So what is the importance of scanner in low power? It is for overall pattern recognition, right? And with the help of this pattern recognition, you can easily go to diagnosis. And most inflammatory dermatoses are diagnosed based on the architectural distribution and not cell type. Now step 2. So you have to use high power view, and when you use this epidermal evaluation do under high power, first question will be whether this epidermis is normal, thickened or thin, right? If it is thickened, like it is hyperplasia, so whether it is acanthosis, which is regular or irregular, or pseudoepitheliomatous. Now what is acanthosis? Already we have discussed in previous video. It is the increased thickness of epidermal layer. Now next you go one by one layers of the epidermis. First, stratum corneum, whether parakeratosis in the form of hyperkeratosis or orthokeratosis, granular layer, whether it is hyper or hypogranulosis, intercellular changes, whether spongiosis is present in the spinous layer or not, keratinocyte damage at the basal cell layer, whether dyskeratosis or civet body or necrotic bodies or acantholysis is present or not, and intraepidermal inflammatory cells like lymphocytes, neutrophil, eosinophils present or not. So here in this slide you can identify intraepidermal inflammatory cells are collected here. So if it is neutrophil, then it is Munro microabscesses, or Kogoj pustule. M, it is in the corneal layer, it is Munro microabscess. So intraepidermal collection is helpful in the diagnosis. Now basal layer at the dermo-epidermal junction. So first you have identified epidermis, Now you look for changes in the dermo-epidermal junction. So at the junction, whether basal layer having vacuolar degeneration or any basal cell damage. Interface pattern. This pattern we will discuss in our next video, but whether it is lichenoid. So lichenoid means whether lymphocytic band infiltration is present or vacuolar degeneration of basal cell layer present or not, or mix. Now look for basement membrane, whether basement membrane is thickened or duplicated or disrupted, and if blister is present, then label it, whether it is intraepidermal, whether it is suprabasal means above the basal layer, or subepidermal, so it is below the epidermis. And pigmentary changes, whether melanocytes or melanophages are increasing amount, or pigment incontinence means whether you can find uh, melanin pigment in the upper dermis or not. So these are the junction changes. Epidermotropism, whether it is present or absent. Now once you have seen epidermis junction, now it's a turn for dermal assessment. So for dermal assessment, low power view shows whether depth of involvement, right? Whether superficial dermis, deep dermis, or superficial and deep dermis, both are involved or not. So you have to see carefully under the microscope in the low power view what is the depth of involvement. Now second is whether the papillary dermis is involved or whether the reticular dermis is involved. Third, this inflammation or findings, whether they are extensive up to subcutis or not, and after that you can identify pattern of inflammation. So pattern of inflammation in the dermis, whether it is perivascular, if adnexa is present, periadnexal, interstitial, and diffuse. So these are the pattern of inflammation in low power view you can identify. Sometimes if granulomas are present or nodular arrangement of inflammatory cells are present, then also you can identify. Along with this, now high power view will help you to identify which type of infiltrate is present, whether these are lymphocytes, neutrophil, eosinophils, plasma cells, or histiocytes. Vascular changes in form of whether endothelial cells uh, means capillary dilatation is or there or not, vessels whether fibrinoid necrosis is present or not, leukocytoclasia or RBC extravasation. So this will help you to narrow down the diagnosis the most. Now also you can identify stromal changes in the form of edema, collagen thickening or necrobiosis, elastic fiber whether it is reduced or fragmented, and granulomas if present whether it is well formed or ill defined, or whether it is caseating or non caseating. Now after that you look for adnexa and some special features and some correlation with these features in the deep dermis and final impression. So adnexa will this adnexal involvement mainly include hair follicle, sebaceous gland, sweat glands, some special dermal deposits like mucin or amyloid or calcium or pigment, whether it is present or not. And if you want to see some organisms, you can decide some special stain also, right? Now after that you correlate epidermal, dermal, and dermo-epidermal junctional change and you classify lesion according to your findings as whether it is spongiotic, whether it is psoriasiform, interface, vesiculobullous, granulomatous, or vasculitis in or neoplastic. So finally, your final step uh, is to classify your lesion in this category. So basically, what this approach suggests, that low power gives you diagnosis and high power gives confirmation of your diagnosis. Now, these are the terminology for epidermal changes, dermo-epidermal junctional changes, dermal patterns which you can identify in low power, and cellular details in high power, as well as vascular and stromal details along with granuloma and some special dermal terminology. So this slide you can have in your desk when you do microscopy, so that you can identify change that you can define easily when you do microscopy. So this is very important slide. Now, what are the different changes in epidermis or dermo-epidermal junction or dermis you can identify in low power and high power? This is I have divided into low power view and high power view. So if you use this when you do microscopy, it will be very helpful for your skin biopsy interpretation. So whenever you see epidermis, use low power to see overall thickness, pattern of hypoplasia, rete ridges, whether it is elongated, club shape, sawtooth or flattened, and the surface, whether it is hypokeratosis, parakeratosis or scalp crust or present or not. Now, high power view, as we have already discussed, start from corneum to the basal layer, and you identify all the visible changes you can identify according to your skin lesion. In the junction, we have to see whether it is interface dermatitis, which pattern is this, continuity is normal or abnormal, whether any blister or clafting present or not, or any pigment alteration. And with the high power view, you can identify basal cell damage in the form of either vacuolar or civet body, whether this basement membrane is thickened or not, and inflammatory cells along with the pigment incontinence. In dermis, involvement or the depth of involvement, which level is involved, what is the pattern, and what are the different types of infiltrate in the high power view you can identify. Now, this approach is helpful, but you should have one checklist for skin biopsy microscopy. Why you need? Because generally, what are the common mistakes we do? First of all, we directly jump to high power, as well as we randomly give description without order. We generally focus only on cells, not pattern, and we miss subtle but key findings like interface changes, depth of dermal infiltrate, whether pigment and incontinence present or not, and finally we write down confusing and lengthy report. And what is the examiner response? Then it is unsystematic approach. So to avoid these mistakes, we need checklist. Another thing, skin morphology is complex because it involves any part of the skin including epidermis to subcutaneous, and these changes are subtle and layered. So checklist ensures no level is missed. And Here, this will also help you to prevent random unstructured description, and for the beginners which jump directly to high power will definitely not help in diagnosis. So checklist enforce logical order, like start from epidermis, junction, dermis and subcutis, and it will also lead to clear examiner friendly report. Now this checklist will also help in emphasizing low power pattern recognition, whether um, we know that most inflammatory dermatoses are pattern based. So this will help you to assess pattern depth and distribution, and high power usually give you confirmation, and it will reduce diagnostic errors, mostly which we miss is interface change or incontinence and depth of dermal infiltrate. So checklist act as a safety net. So this is here I have given you a checklist for epidermis. So this checklist include thickness of epidermis, stratum corneum, whether it is hyperkeratosis or para or alternating, granular layer change, and intercellular as well as intracellular change. These all checklist will help you to differentiate whether this is psoriasis or lichen planus or any bullous lesion or viral infection, right? So when you do skin biopsy microscopy, I uh, when you do microscopy, you must have this checklist in your hand so that you can easily tick your findings, and at the last when you complete your microscopy you can identify what is exactly the pattern of this lesion. So as we have seen epidermis checklist, here dermo-epidermal junction checklist include basal layer changes, whether this is vacuolar or basal, you just have to tick mark. Interface pattern, lichenoid or vacuolar, basement membrane, then blister or cleft level, so that you can identify whether this is in the pemphigoid group or pemphigus group. Differentiating vesiculobullous disorders, pigmentary changes, and epidermotropism present or not. Now golden rule is describe epidermis first, and then dermo-epidermal junction, that is pattern based approach, will help you to diagnosis of your microscopy. Now dermis, in dermis checklist is long but very helpful, like whether pattern first in low power, so that you can easily make your correct diagnosis, like depth of involvement, distribution and pattern. In high power view you have to see cellular details, which type of inflammatory cells is seen, cellular activity. Then also with this you have to see vascular changes, very important change, whether you can identify any perivascular inflammation or not, or any vasculitis features are present or not. Stromal changes in the form of edema, collagen and elastic fiber identification, whether they are normal, thickened or sclerosed. Granulomas if present, whether it is well formed or ill defined, caseating or not, foreign body type or naked granulomas, and adnexal involvement including hair follicles and all the glands, dermal deposits in form of mucin, amyloid, fibrin or pigment, calcium, or any organisms. So once you uh, complete your microscopy with the help of checklist, you can make your final reporting format where you have to write down that sections show all three components like epidermis, dermis, and subcutaneous tissue. Now your findings. The epidermis shows changes of that you have already tick marked in your checklist, so it will be easier for you to write down now. Dermo-epidermal junction show this pattern we are going to discuss in next video. So next the dermis shows this is inflammatory infiltrate with or without vascular stromal adnexal or granulomatous changes. So this is your microscopic uh, format where you can add your uh, microscopy findings and make a one conclusive report. So with the subcutaneous tissue, if punch biopsy or incisional biopsy is there and subcutaneous tissue if present, you can add also whether it is unremarkable or showing paniculitis or not. And finally, histopathological features are consistent with the clinical diagnosis which is given by dermatologist. So for this final line, for the conclusive line, you need to see next video in which we are going to discuss a pattern based approach in inflammatory dermatosis and most important Weedon scheme and Ackerman scheme. So I hope now you will easily do skin biopsy microscopy with the help of this checklist. You make your checklist ready when you do microscopy and you write down your findings. Once you gather your findings, you can easily make one pattern. So for pattern, we will meet in next video so that you can learn all the patterns and you can make your final diagnosis for particular inflammatory disease. So thank you for listening, and yes, if you found this video helpful, please like, share and subscribe, and do not forget to comment, and thank you very much.